President, National Board of Examinations, Dr. Vikram Matthews, Director, Christian Medical College, Vellore, Dr. Achal Gulati, President and Vice Chancellor of Mahatma Gandhi University of Medical Sciences and Technology, Jaipur, and Dr. Anna Funpok, Global Head of Healthcare, KPMG International, and Healthcare Senior Partner, KPMG, in the Netherlands. We request you to kindly settle in, please. Okay, I request Dr. Sanjeev Singh to kindly take over. Over to you, sir.
A very good morning to all of you, and I know there would be this bio break or a break which would be necessary, but we'll get started. There has been a significant delay, but it's a glittering panel with us discussing a very, very important topic. We have seen the report which was released by KPMG, and I would really like to thank them for doing the fantastic work. India has a population of 1.38 billion with a density of 422. They share almost two-thirds of the deaths because of the NCDs. The probability of dying between 30 to 70 years is almost 26%. The disease-adjusted rate for a communicable, maternal, neonatal, nutritional has reduced, so there has been significant work which has been done. But then the contribution through NCD related to DALI has also increased by 30%. And we have seen NCDs, obesity, geriatric and comorbidities been increasing. There has been a 4.6 million healthcare workers which are available, both doctors, nursing and midwives. But then we are lowest in the BRICS area. We have a shortfall of 1.5 million, and we need people to be able to man that population by bed density. There has been a significant fall of family physicians, pediatrician, obs and gynae, general surgeons, and the specialist which is available. But then we saw yesterday, we heard our chief guest, Dr. V.K. Paul. There has been a significant work which has been done through Ayushman Bharat, through infrastructure mission, through Pradhan Mantri Swasthya Suraksha Yojana. He also mentioned about AIIMS, 22 AIIMS being commissioned. We have seen a drastic 112% increase in medical colleges throughout the country. We are at 706. And then there is this population increase, there is an NCD increase, there is a significant shortfall, and then there is medical value travel, health insurance, out-of-pocket payment, which is all reducing. So we wanted to have this theme of medical education and look at all the parameters, how do we sort of fill in those gaps, and what would be the best way to look at it. So with the panel, I have Anna, and she said that if you want to locate her, it's only at the airport. So she stays at the airport and she stays at the hotels. And she's been traveling, an avid traveler, and she just visited, I'm unable to keep track, Brazil, Vietnam, Saudi, and then she is again going to travel many other countries. She is a global head for healthcare and a senior partner at KPMG, and thank you, Anna, for being with us. We have Dr. Vijay Oja. Dr. Vijay Oja is a graduate and a postgraduate from BJ Medical College and is a very famous urologist par excellence and has an adequate training from Apollo Hospital, Chennai, and he is a specialist in urology at Indira Gandhi Institute at Pondicherry. And he is now acting chairman for the most important regulator of medical education, that is NMC. So thank you, Dr. Oja, sir, for being with us. We also have Dr. Abhijat Seth. He is a stalwart and he's a very famous cardiovascular thoracic surgeon. He has done his MBBS, MCH, MS, MCH, all from Gujarat University and is at Apollo. And presently, he is the president and of the National Board of Examinations. And I would really like to express my gratitude for taking your time out. He was traveling to US and he made it a point to be with us. We have Dr. Achal Gulati, sir. Thank you, sir, for being with us. And He's going to make a very interesting presentation, so please hang on and listen to him. He has done his MBBS from Delhi University and MS ENT, and has done some remarkable work in otolaryngology. And he's presently the president and the vice chancellor at Mahatma Gandhi University, and he has done some amazing work there. So thank you, sir, for being with us. We also have Dr. Vikram Mathew. He's the director of Christian Medical College, one of the premier medical colleges, and we look up to this college for anything which happens within the country. He's a physician scientist, and he's an hematologist, and his extensive work is in leukemia. And he basically has also attained his fellowship from Washington University, numerous clinical trials, numerous research programs, and has worked extensively on drug resistance. Thank you, Dr. Vikram, for joining us. So we'll get started with a small video presentation, and then we will have an opening remarks from all the panelists. I would like to extend my thanks to Lalit Mistry and his fantastic team at KPMG for releasing that document, preparing that video. And in continuity, I'd like to just start with you, Anna, and understand the global perspective in the future of medical education.
Thank you very much, Dr. Rithing, and it's a real honor to be here. And let me start by saying congratulations, my colleagues, and of course Vicky, on this what I think is a very strong and very strong publication and thought leadership. Excellent it is. So, like Dr. Singh said, I pretty much travel the world. So at this moment I'm doing, I think, 8 countries in 12 weeks, speaking to 1,500 leaders in healthcare organizations on 4 continents, ranging from Brazil to the Middle East, to the US, to Canada, to UK, and quite a lot of other countries. So in that sense, that gives me the opportunity to have a real global perspective on what's happening in healthcare. Now, before I dive into medical education, some reflections on what I see happening here in India. And I have to say that all my visits to India and in the conversations with our clients here in India and with my colleagues, I am truly impressed, and this is an honest impression, I'm truly impressed by what India is achieving in its healthcare mission. I think the Ayushman Bharat program is a unique program in terms of its scale, in terms of the 5 pillars that are underneath it, in terms of the way in which the 5 pillars are integrated, and actually all of India is working on sustaining their healthcare system and building a very strong healthcare system for the future. So in that sense, a real good trajectory ahead. But there are some buts, and I will reflect on you on the buts. But before I do that, I want to give you a few reflections on what I see happening in the field of medical education worldwide. 7 trends. The single biggest trend, and we had a discussion about that yesterday already, the biggest trend that's happening in healthcare is the move from what I would call man-made healthcare, human-made healthcare, into healthcare that's data-driven, that's technology-driven, and that has a very strong digital base. Now, that needs to be reflected in medical education. Medical education is still pretty traditional. We had a conference last week with worldwide leaders from healthcare systems and from educational institutions. The biggest message there is that medical education needs to start tapping into that new world for healthcare, making it much more data-driven, making it much more technology-driven, and actually helping our students and helping people that are working in healthcare now, educating them to deal with that new age for healthcare. The second point that I'm seeing is that I see education moving away from what I would call a little bit, maybe negatively, knowledge pumping, knowing all the facts, to something that's much more competence driven. With digital, with technology, of course knowledge is very important, but it's not going to be at the core anymore. It's very much more about the competences that you need to deliver good healthcare. So that move from knowledge to competence is the second field that's changing. An important field that we see changing is the move from very much hospital-based healthcare to much more integrated healthcare, community-driven healthcare. And that means that our education needs to move from something that happens in professional silos to much more being based into interdisciplinary working. And interdisciplinary working means between medical specialisms, but it also means between medical specialisms and fields like nursing, dietitian. Just think about the NCDs and the importance of real, very good nutritional advices. So it needs to become much more interdisciplinary, and the education needs to play into that. In education, what I see is a shift from thinking in medical specialist only to a system that's much more based on integrative care, meaning that the education of nurses, the education of GPs and primary care doctors, family doctors, but also specialist nurses taking up quite a lot of the roles of specialists, medical specialists, thereby alleviating the burden on medical specialists, especially the super specialists. So oncology specialized nurses, diabetes specialized nurses. We need to move away from doctors that work in ivory towers and education that takes place in ivory towers towards a much more community-based curation program. What we're seeing is, and that's what I'm seeing worldwide, there is a very big shift happening at this moment from treatment of individual patients to a much more population health approach, to a much more proactive preventative approach. That means a big change in the skills that we need in the medical field. It needs a big change in the way in which we are, in the competences that are needed. So doctors need to be trained much more in that population health approach, interdisciplinary approach, and that move from curation to prevention. Change is happening so fast in the medical professions that we need to move away from where we start with like a 6, 7, 8, 9 year long specialized education to something that focuses on lifelong learning, obtaining new skills all the time, and also micro-credentialing where doctors are actually trained in the skills that are needed at that moment. So just imagine you're an oncologist and you're going to have this new patient in, and you haven't done that sort of cancer for a long time. Wouldn't it be very good if you can then take a 10-minute course in the morning, 15-minute course in the morning, which gives you all the latest updates on what's happening in that specific field. So lifelong learning. And then the last, what we saw worldwide due on the back of COVID was a huge burnout and attrition in medical specialists, in nurses. And we are realizing, and medical education is starting to realize, that they need to shift the needle from also to well-being and resilience, being able to deal with stress. So these are the 7 big trends that we see happening in healthcare. Now, what's happening in India? And before I go into the challenges for medical education in India, the introduction of universal health coverage in India, I think, is a very big asset of this nation. It's going to improve your health, it's going to improve your wealth, because good health leads to greater productivity, leads to more economic wealth. However, there is a big danger there. The danger of introduction of universal health coverage is that you create a system where healthcare at the highest level is free for all. And the last thing that I think India is wanting is a system where everybody runs, when they have a little ailment, then they run immediately to a tertiary hospital. I'm comparing a little bit here to the US. What happened in the US? What's happening there is that the US is, in terms of expenditure, by far the most expensive healthcare provider in this world. In terms of quality, it is pretty low. And that is because there is a too strong focus on tertiary care. What India needs to do in its whole approach and its medical education is a two-pronged approach. The one prong is the focus on primary care, community care as the gatekeeper of your healthcare system, trying to keep people as low as possible in the system and as much focus on prevention and early intervention. However, that second prong is also important for India. Due to the changing infrastructure, due to your changes in your reimbursement system and the capacity, there is a big shortage of specialists and super specialists. So India needs to take that two-pronged approach where you are training GPs, nurses, community workers, and at the same time you are training your specialists and your super specialists because there's a shortage. There's a historical shortage that you need to sort of build up again. So in India, there is a rising demand for specialist care, and that's something that needs to be addressed. So more, and read all about it in the report that KPMG just produced together with Vicky. So work on having more places, easier access, shorter programs, re-evaluation of your programs. That's one. The second point of attention for India is the geographical disparity, especially between the rural and the urban areas. So in your medical and education infrastructure, you need to start thinking about how are we going to make a more geographical, equal approach to that, especially training for the rural areas, especially training for the areas where there's still inequalities. And then the third point is actually in your whole program is that your education needs to start focusing as well on research and innovation. When I heard yesterday what's happening in the digital space in India, the innovative character of the Indian society, I think India can actually be a leader in innovation in healthcare. But it means that you have to focus your medical education not only on learning your specialty or learning your discipline, but also focusing on education, on research and innovation going hand in hand. So that you really entrench that innovative character, that data and technology-driven approach into your education as well. I think India can benefit enormously from the very strong PPPs that you already have. And so in your educational system, start working with these PPPs, working together between private educational systems and your public educational systems. To finish off, I think India has made great advancements in healthcare. If I compare it globally, it's one of the most exciting examples of advancements in healthcare. These advancements in healthcare now need to translate into tangible opportunities for everybody. And that gives a huge responsibility to the sector to actually build a system where you have enough specialists and super specialists, but also build a system where your primary care and your community care acts as a gatekeeper, and build a system where data and digital is actually moving the needle from curation to prevention, but is also moving the needles to making care available in remote areas. There are very much valuable lessons for the rest of the world in what's happening in India. I think if you're able to move forward from this pathway, strengthen your education, strengthen your innovation culture, India can really be the beacon of hope and innovation in healthcare for the rest of this world. Thank you.
Thanks, Anna, for those insightful words. And you have used all the key words which is important: resilience, change, promotive, preventive, data, technology. But please write it that we are also doing good. But whatever happens in India happens through our regulator, which is NMC, and we are fortunate to have Dr. Vikram Ojha, sir, Vijay Ojha, and we would like to have your opening comments.
Good morning to everyone. Dignitaries on the dais, Sajjano or Sannari. The topic that I have been given is making our graduates and postgraduates future ready. And as a chairman, acting, and president of the Postgraduate Medical Education Board since last 4 years, it is expected from me that what efforts the NMC is making for making our graduates and postgraduates future ready. Before I touch upon the subject, I would like to make an opening remark that as an administrator and a regulator, I believe less in speaking and more in writing. If you cannot write anything, there is no point in speaking about it. So whatever you speak, you should be able to write it, then only you speak. We have tried our best since last 4 years to do that, and I hope the active participation and input from all of you will make things further better. Next slide. Shall I? Yeah. So when we are talking about the future ready, do we know what is future? All guess and imagination. And should we worry about the future? The answer is yes and no. When the no is required for our own mental health, but instead of the worry, it should be a concern. It is a concern for the well-being of ourselves as well as the future humanity. The concern arising out of the sloka of the Gita, involvement without attachment, and karmanyeva adhikaraste ma phaleshu kadachina. With this, I will say what concerns we are going to address. So, having decided that we have to be prepared for the future ready, then question comes, what future? What future are we envisaging, and by what way? The most important part of the future and for what are the things which we require is improve health care of sick patients, prevent illness, and make society healthy, and better old age care. The first part we have been all talking all around and we have been doing and well taken care of. But the second and third part, that is the B and C, are most neglected one. Can you imagine a person standing in front of you has not taken a single antibiotic or paracetamol since last 40 years? Yes, it is true, and it has become a possible. When I was at the age of 25, when I get first high, lot of young age to you get it, 104 temperature. At that time I decided that I will not take paracetamol which is lying in front of me. I had just become a graduate. And I'll be happy to tell you that next day it was 103, next day it was 102, and then after second or third day I started eating normally. There was no GI disturbance, nothing. And this continued till 40 years, and now I am speaking that I have done it for 40 years. This can be done by everyone, and it requires a lot of thinking and courage. This has been possible because of our Indian philosophy and yogic traditions, and which I inculcated in myself through the guidance of Maharishi Aurobindo. Now we will move on to what is the future. So what the future, we have to be prepared for various problems which we are going to face. The possibilities of increased infection-related diseases are high because of a lot of travel, because of the lack of immunity, etc., etc. Possibilities of decreased immunity because of the poor habits, nutritional problems, etc. Environmental factors are also going to cause a lot of disease problems, pollution, allergy, And then we can imagine the future of nuclear war also. So all kind of disasters and nuclear war and all the things also we have to keep in mind for the future readiness. The increased incidence of cancer, all of us have discussed a lot, and this is because of the factors already mentioned in 1, 2, 3, and many others. And the last but not the least is that there is an increased demand of better care of well-known disease. Whatever are established and well-known disease, day by day there is a demand is increasing, and so we have to be future ready for taking care of those diseases. So now, as an administrator, you learn that in the first 4 or 5 minutes of your talk, you finish about something which all of you say that all the things we were knowing. So now the remaining 3 minutes I will tell about what is happening in NMC, what is new and what is different. The credit goes to our Honorable Prime Minister, whose vision made the difference by creating National Medical Commission. It was not that the Medical Council of India was having the dearth of brain. There were very brilliant people who have worked, and they have done very good job for whatever the work they were assigned. But there was a need of a full-time body who sits round the clock together and discuss and come out with some solutions. Here, at present, NMC, they have got 13 full-time members. 4 are the president of the boards, and 1 is a chairman, and then another 8 are the members of the board. So out of these 13, initially we had only 8 of them, and we worked whole day, discussed about various issues, interconnection with the undergraduate board, postgraduate board, ethics board, and assessment board. This was very much required to come out with a good regulatory framework and the necessity for the future readiness. And what we have done is that we have come out with the few regulations which were never done in the past. The regulatory work of the Medical Council of India seriously started in year 2000, or we can say 93 onwards, but the main thing, postgraduate regulation was started first available with us in a gazette notified form is in 2000, while MMCI was there in 1956 onwards. So this, it took so many years for drafting the proper form of a regulation, and then after it continued and with lot of amendment, around 40-50 amendments were there in that, and then we had come with the challenge of making the new postgraduate medical education regulation and undergraduate medical education regulation. These are the two mother of all the regulations, or parents of all the regulations, and based on that, the various regulations have come out. So these are the two regulations, postgraduate medical education regulation, and that we came out in 2023, and undergraduate medical education, that also came out in 23. These two regulations have made various provisions, and when we thought that there is nowhere in the world, there is a serious thinking about the medical qualification. There was always a confusion in the medical council, whether sometime it may be deliberate or otherwise, that difference between a course and a qualification was misunderstood. The qualification was written as a nomenclature in our regulation, past regulation. The qualification list was not having any serious mention, and it was just written under the heading nomenclature. And then we thought that there is a need for changing and making the regulation, and probably first time in the world, this large scale qualification regulation has been introduced for such a large implication. Probably others may have smaller things, but we have a very large implication, nationwide implications. And this regulation, qualification means likat. The MD General Medicine is a qualification. And when we do the 3 years training for this MD Medicine is a course. So previously it was confused between qualification and course. Now we have come out with this regulation, a list of the qualifications which are there, which have been there were confusion. M full stop, D full stop or MD. That also was not clearly mentioned, and there was many places there were differences in many of the government documents also. We have made it very clear, we have made this regulation, and now included some of the qualifications like 1 year course PDCC and 2 years course PDF, postdoctoral fellowships. The world is going into a smaller programs because there are a lot of sub-specialization and it requires a development. What Madam has told, that there is a need for a development of the sub-specializations and the smaller specialities for the experts. And for that, we have now introduced the postdoctoral fellowship, a 2 years program, and the PDCC, that was a 1 year program. These are considered as an additional qualification. Previously, they were there. No one had bothered that it should be an additional qualification. Now, it is an official seal. Anyone who does this program through the NMC will be considered, that program can be registered as an additional qualification in their list. That will make the difference for their legal purpose also. So with this, I'll say that this is what we have introduced is a recognition of the medical qualification regulation. Please go through. The another question came was improving and maintaining the standard of medical education, and for that there was no regulation which we came out, maintenance of standard of medical education regulation 2023. Previously, that purpose was being served by the process of recognition. So once a new course is started, at the end of the 3 years, they have to get recognized, and at the 5 years, it requires a renewal. But there used to cause confusion among the students' degree registration. So we decided that we come out with the proper regulation, and this regulation will have a penalty clause. So if the standards are not maintained, then it is not that the course has to be stopped, but there should be a lot of other provisions, a lot of reformative measures are required rather than just stick in our hands. So with this purpose, the maintenance of standard of medical education regulation has been promulgated. And there was no medical standard, PGMSR, standards of regulations, means standards required for postgraduate medical training. And that PGMSR, we have come out first time. This was never there in the history, but the UGMSR was there, but PGMSR was not there. So this we have come out, and we have come out with the revised edition called PGMSR 24 also. With these things, we have tried to improve the standards of the education. And the last but not the least, the development of the various specialities was not properly addressed, and that was causing a lot of confusion amongst the stakeholders. As a part of that, we have we have drafted TEQ 24, that is a revised TEQ, Teachers Eligibility Qualification Regulation 24, which will come in the public domain. Draft will come, and which has addressed the requirement of the consultant for the newer specialities. There were always, when we are talking about the developing the newer qualifications, we have to talk about who will teach those qualifications. And there are some people who are pioneers, but then for them there was no provision. So then we have made an official provisions in these new regulations called Teachers Eligibility Qualification, and by that way it will pave the way for the development of the newer specialities in the country, what Madam said about the need of the development of the various specialities and further future readiness of the science. We have to be ready for the possible future disease problems. By that, we will have to include those issues in our syllabus and promote the institutes which are doing that specialty work in that newer fields, and start even develop those institutes and departments which are particularly doing this work. With this, I thank you very much for giving me this opportunity.
Thank you so much, sir. That is some fantastic work with bringing out those regulations which was not existing and paving the right way. The other phenomenal work which gets done is through NBE, and I would request Dr. Abhijat Seth to have the opening remarks.
Namaste and very good morning to all dignitaries on the dais, off the dais, all senior faculties and my colleagues, ladies and gentlemen. On behalf of the National Board of Examination, I extend my gratitude to the FICCI, Dr. Sanjeev Singh, for inviting me to have an interaction with all of you. As you are aware, with the National Board of Examination in Medical Science is almost 4-decade-old post-graduation education body, and it's running its own courses, which is now recognized by NMC with certain conditions, and these courses are DNB courses, DRNB courses, and we are specially running the skill enhancement courses, which is fellowship of the National Board of Examination to serve the subspecialty development. Going to the topic of adapting the technology and innovations, let's look at the medicine, how medicine is advanced. Even when I was studying the medicine and now, medicine has become more complex. Lifestyle has introduced different diseases in more intense manner. Technological advancement has gone more significant. Even all these new innovations are moving from generalized medicine to the personalized medicine eventually in couple of decades. So lot of complexity has gone place in the medicine. I remember in our time, the gold standard was a physical education, means face-to-face education. And certainly many of the old teachers still recommend very strongly and attached to the physical education, which is absolutely true because it served for many decades to the nation. But looking to the complexities, we need to now advance, we need to change. And we need to change it in the way that we accommodate all the new technologies, all the new innovations, and make our new generations much more ready with the advancement in the medicines and innovations in the medicine which has happened. So what we developed at National Board is a 5 digital model, which is one part is a physical education, the second part is a skill and virtual education, as you have learned from Madam Anna and NMC, that we have moved to the competency-based medical education. And here where the second component is going to play a big role, which is skill enhancement and skill and virtual training. The third component is a digital education. And this digital education include the whole arena of webinars, the whole arena of different forms of e-learning programs. And certainly the COVID has taught us, and this has advanced to a significant level. What is the reason that we need to advance ourselves into this education? Now, first our question is it going to replace the physical education? Until now, the most of studies have said no. The physical education is still the gold standard. But certainly, the other forms of education will complement your existing gold standard education, and certainly it will enhance the capacity of and scope of the current medical education to the expected and desired level for these new changes. The other important thing is skill and virtual training certainly become adjunct to the physical education, where the scopes are there, and certainly it will give a strong boost to the competency-based education. While the digital education, the biggest advantage of the digital education is it will bring the uniformity. In a physical education, we had major problem was, although it was a wonderful face-to-face direct dialogue with the learner and trainer, as well as it was a vertical relationship. All these great phenomena was there, but the biggest problem with this education was we couldn't address the diversity of the medical education in our nation, and that is something where these other forms of education, which is which is largely done through the adoption of technology and innovative techniques in the medical education, is going to serve the purpose. The other issues which I always look into this education is digital education. What are the pitfalls for the digital education yet? There are studies which has given support to the digital education, but certainly it lacks the human touch which you have in the physical education. It is more a horizontal relationship rather than vertical relationship where you have a role model to mentor, to teacher, and it was a wonderful relationship which in Indian diaspora, the guru-shishya relationship, this all used to happen. This is eventually going to fade away if the digital education is going to get more and more intense and more severe. At the same time, the digital education will certainly address the diversity by bringing the uniformity. I relate the quote of Sir Benjamin Franklin. He used to say that at 20 years, wheel reins means your aspiration starts working at 20 years. Your wheat reins at 30 years means your intellectual works at your 30 years. And your judgment works at 40 years, means your insight works at 40 years. What it means? The evolution of your mind from your dreams and aspiration to the best of clinical insight, it takes its time, irrespective of whether you are going through physical education, you are going through any form of education. And certainly, this exactly gives us a philosophy in the thinking that how we frame our education, how we adapt the technology, how we adapt the innovation in our medical education to ensure that this pathway persists, but it gets as shortened as possible through the complementing way of digital and technological enhancement through skill and virtual training. This is exactly what we need to work as a responsible postgraduate medical education body. The last important thing which we recognize that what are the limitations in adopting the technology and innovations. The main limitations, as we recognize, there's a very interesting and wonderful presentation by Jennifer Wong. She's a New Zealand, she's a faculty from New Zealand, and she has written wonderful synopsis of how we can get better with the technology and innovation adoption in the medical education. And she mentioned, their group has mentioned about social dynamics. What the social dynamics tells all about is the same, that we need to create a framework, the organizational framework, where the not only individual, but individual is supported by the trainers, by the learners, and also we need to see the effect on the ultimate index, which is a patient outcome. These all are clubbed together, and that forms the social dynamics. And this social dynamics is going to work, and it will enhance the technological as well as the innovation adoption in our medical education system. What we mean to say that we need to get our human resources ready, and we need to create that perception in the community, patient community, as well as the medical community, that the technology and innovation adoption to the best of the current need will help us not only bringing the quality of the medical education, but it will also affect the best of the patient outcomes, and it will help us to bring the best patient outcomes, and hence the primary endpoint of the medical education will succeed for the next generation. And certainly at National Board of Examination, we are there to take this forward. And as you see, recently we have introduced in our website the skill centers across the country. And we could see that only the handful of the skill centers, only 12 or 14 skill centers has registered with us. But I am pretty sure that in coming time, we will get far more educators, skill educators across the country to help our postgraduate students, irrespective of whether DNB or they are from the NMC. They will help the students to bring the best of the competency-based education, and certainly it will keep us to go ahead with the time in terms of all innovations and rapidity of the medical research and discoveries. Thank you so much.
Thank you so much, sir. Wonderful to see that from physical to skill to digital work which is happening, and the one person who is having intellect and judgment intact is Professor Achal Gulati ji. We'll have you share the opening remarks, sir.
Can the slide be projected? Yeah. Thank you so much. A very good morning to all of you. When I was given the topic of ingredients of high quality medical education, ingredients brought to my knowledge one of the three things which I loved. In no order of preference, my family, medical education, and food. And when I looked at the ingredients, I thought in medical education, what are the ingredients? What are they? Where are they found? What is the process of obtaining and integration of those ingredients into the food process? Where will the whole process start? Is there an endpoint for it? These are all questions which cropped into my mind. And then I remembered this song. Can I have the audio, please? I can sing it to you. Please. This says, कहाँ शुरू कहाँ खत्म, ये मंजिलें हैं कौन सी, न तुम समझ सके न हम. Where does medical education start? Where does it end? What does it have? It's all a matter of conjecture which came into the thing. So this is what the ingredients are all about. So when we talk about food again, the ingredients, elements, and the spices which go into the food. Indian food is a very complex situation, just like the medical education is. Both of them are equally complex. So when we talk about that, what needs to be mixed in the proper manner, in the proper direction, in the proper quantity, what needs to be mixed, in what phase it needs to be mixed, all this forms the basis of good cooking. And the same thing works in medical education. What exposes you to medical education? What exposes you to the content of the medical education? What is the curriculum design in the medical education? What are the teaching methods which are used in medical education? How do you assess that? What is the feedback that you have? All these things are going to be important when you look at the high quality medical education. It's not just medical education. It has to be collaborative learning. It has to be collaborative training. You have to collaborate with the various agencies. What am I producing my doctors for? I'm producing my doctors MBBS, MD, MS, DM, MCH, PhDs and whatnot. Somebody is going to be probably a general practitioner, a specialist, a broad specialist, a super specialist, a researcher, somebody is going to go into the industry, somebody is going to go into administration, management, and somebody is going to totally leave his profession and enter probably into some other business. So am I making that person ready for the world when he comes out of it? That is where I need to take the opinions and consultations from the various stakeholders as to what I need to include in my medical education. Using a variety of learning resources. Today we have so many learning resources over a period of time. We have so much of computerized issues, so artificial intelligence, machine learnings, so much equipment is there. COVID taught us a lot. COVID taught us how to respect life. COVID taught us how to respect death. COVID also taught us how to become computer experts, how to communicate online. Today, early there was a time, I am a vice chancellor of a university, so it became the VC of a university. So it was synonymous that you are a VC, oh fine. Today VC, who remembers vice chancellor? Today VC is video conferencing. Everyone talks about VC and VC and VC, and that's what life has become all about. So we have learned so many things during COVID that element has to be brought into our medical education when we are teaching it to make everybody ready. Emphasize on lifelong learning. Things are very simple. What I learned probably in 1982 when I was doing my MS ENT in PGI Chandigarh, paper 4 was recent advances in ENT. And that today, 42 years, 43 years later, I teach in history of medicine. It took 40 years for recent advances to turn into history of medicine. But remember, that was at that time and that is today. Our students, our residents, our children are not going to wait for that long. What I teach them today in the next 10 years is going to be history of medicine, and for my children, what they teach them 10 years later, the next year it is going to be history of medicine. That is how fast science is changing. So I need to develop a habit of de-learning, learning, and relearning. That is something which is very important. It's not that I was taught this thing, therefore it has to be taught in that way. It's my way or the highway. No, it's not that way. It's not my way, not highway. It has to be a collaborative learning and teaching phenomenon. Ingredients, elements. So how do we spread this aroma of my food which is there? Food smells lovely everywhere. And this aroma of medical education also has to percolate right across all bodies of all societies. So there have to be certain principles in life over there. What principles? Quality assurance. There has to be quality assurance. And who will do that? The national level. It will be done by the regulatory bodies. NMC, we heard Dr. Vijay saying, we heard Dr. Abhijat saying, they are regulatory bodies who are looking into the entire development of the medical education. What was taught to me at that time was very good. I don't deny that. But today, it probably needs a change, and that is why PG MSR, UG MSR 2023, 24, otherwise we are totally going out of control. Enhancing the quality of medical education is that responsibility. Quality management. Quality management has to be done at the institutional level. We may make regulatory issues, but who's going to follow the regulatory issues? It is the institutions who are going to implement it. Until the institutions implement it, there is no way I can bring about a good quality education. So institutions have to put their hand up, the other hand on their heart, and say, I shall do my best and I shall do what the regulatory authorities prescribe. Yet they have the power to alter the thing to suit the system. India is not the world. The world is not India. I'm making my student ready for India, but like my Prime Minister says, make in India, make for the world, and that is what I have to make my student ready. So the medical institutions have to be honest with what it is. Today, the NMC has brought the culture of stopping the Inspector Raj. That is something which is a revolutionized keychain thing which has happened. And what you are going to say, what Dr. Vijay said, that there has to be punitive measures if you don't follow them, that is what is required. And then comes the affiliated local educational provider who shall provide the quality control. NABH, NABL, NAC, all these things need to be brought in so that I maintain the best standards. So again, coming down to a few more aromas which are there. Patient-centric approach. I need to teach my students what my patient-centric approach is. These aromas are going to whiff across everybody. Global accreditation and leadership. My student has to be ready for getting the leadership of the world. He has to be ready for the world. It's not that the Chinese or the Japanese or the Koreans are bad surgeons. They're very good, excellent surgeons, they're excellent teachers, they're excellent doctors, physicians. The problem is maybe the presentation skills may not be that good. India has the cheesecake because we are good at presentation, we are good at presentation of our skills and everything. Innovation and advancements, that's something which is undeniable. We have to have innovations and advancements built into it. Today we are leading the world across in all sorts of surgeries. Lifelong learning, adaptability, we need to adapt ourselves. Teaching, research and clinical practice, something which is very important. I need to integrate all these things. Everybody is not a good teacher, everybody is not a good researcher, everybody is not a good clinician. A good teacher may not be a big professor. A big professor may not be a good surgeon. So look at it that way. Everybody has something to teach you. Some teach you how to do a thing, some teach you how not to do a thing. He's teaching you something more important, how not to do a thing. So all these, every person is going to see and a mishmash of everything. A good teacher, a researcher, and a clinician in the department, when three of them marry, is going to bring out a lovely thing. Clinical rotations, continuous quality improvement, skill development, professional development. So many things have been learned, so teachers need to learn. Ultimately, what are we looking at? We're looking at the GIGO principle, garbage in, garbage out. If I feed in garbage to my students, I'm going to spew out garbage from the students. My teachers have to be ready to teach my students so that they come out as brilliant individuals. Diversity and inclusion, right across all socio-economic status, I have to have everybody over there. Accessibility and affordability, something which is very important. Medical education has to be affordable. I was calculating one day, it takes approximately 4 crores to develop, let us say, an MBBS and a MS in radiology or orthopedics. So I told my bank friend, I could just calculate the EMI if I have to pay off 4 crores, how much will it cost me? He said 5,62,000 every month for the next 18 years continuously from the day you pass out. Can you imagine if I have to pay 5,80,000 per month for 18 years, where is my morality and ethicality come into the picture? I'm going to lose my ethical principles over there and try to earn as much as possible so that I can pay back. Continuous development and monitoring and development. Again, I have to keep on up the pace. So at the end of the day, someone has to take the responsibility for integrating all these ingredients for creating a high quality that we have talked about and we are talking about. Who does it? Medical teachers, regulators, universities, government, administrators, stakeholders, industry, corporate, judiciary, everyone has to chip in with their inputs, and most importantly, where the finger is pointed out is at you. This is again a song which I really wish it could have played the song. Our medical education and educationists have been good over the time, fitting the bill as it should, just like this masterpiece. Which one movie was it? Mughal-e-Azam. Anarkali over here. And this was one song which was, I think, the best in the world, which was created as a movie, flawless. Would anybody in the audience who's seen this movie, how many times, do you think this song or this movie needs a change at any point of time? It is such a beautiful movie. I don't think anybody would like a change in this, because this is what perfection is all about. Anarkali wanted to be the Malika-e-Azam for one night. She became the Empress of India, of Hindustan at that time. She became Sheikhus, and the Zill-e-Ilahi gave her whatever she wanted. Mang kya mangti hai Anarkali. And therefore the thing continued, and Anarkali was the happiest. This is what medical education should be. One day, somebody asked waqt, somebody asked time, मैं तुमसे हर बार क्यों हार जाता हूँ? Why do I lose to you every time? And time gave a very beautiful reply. He said, धूप हो या छाँव, काली रात हो या बरसात, come what may, in all conditions, अच्छे हालात हो या बुरे, मैं तो हर वक्त चलते रहता हूँ. I'm walking all the time. That is why I win. You also walk with me all the time, you will also win. So I need to walk with the time, change with the time, change medical education to bring it. So we need to change with the time, walk with the time, be dynamic, because what was recent advances sometimes back is history today. In the last slide, we saw Anarkali as having got everything. But it was after that Anarkali realized that nothing is ultimate. And so she changed and moved towards better options. This song, I would have again loved you to hear it. This says, छोड़ छाड़ के अपने सलीम की गली, अनारकली disco चली. When Anarkali, after having got everything in life, she moved away from there, went to the disco, and yet she was remembered throughout lifetimes. This is what Anarkali is. This is what Anarkali teaches us. Movies is not only entertainment. Movies is entertainment with education, what Anarkali has said. I thank the organizers. I thank Vicky. I thank Dr. Sanjeev Singh and everybody out here for letting me be here and teaching and making me change with time, over the time, moving towards a Swachh Bharat, Viksit Bharat, while making in India and making for the world by training them in India. Thank you so much.
Thank you so much, sir. That was the most delicious and sumptuous and a perfect presentation, and an anarkali presentation. Thank you for being the Mughal-e-Azam. We'll quickly switch on to, sir, he has given a good ingredient and we'll like to understand, is it all working? We are slightly running out of time, so we would wish if it could be delivered faster. Extremely sorry about that, sir.
It's okay. I'll start with my famous last lines. I will try to be brief, and however long that takes, it will be to be brief. After that talk on food and dance and music, it's going to be a tough act to follow. I want to thank the organizers for having me over here, and I'm going to start with a few disclaimers. My topic is what has not worked in medical education. So I may come across as being a cynic and, really negative. It's easy to be that, actually. If you had given me 10 minutes to talk on what works in medical education, I could have easily done that as well. But as it is, I'm going to be talking on what does not work. There are people who do the hard work over here, Dr. Vijay Ojha, with the NMB and the NMC, etc. It is not easy to run a country of 1.4 billion, maintain standards, and develop systems and processes that exist today, which we take for granted. They work. They have problems and challenges, and we can continue to improve for sure. But there are a lot of things that work for us. But to concentrate on what does not work, I'm going to cover it in three basically brief points. One is on the medical education process. Second is on disproportionate attention to certain aspects of education. And finally, I'm going to talk about skewed priorities. So when you talk about medical education, I'm happy to hear that there's a lot of effort with standardization, etc. The ground reality is there is a lot of disparity with regards to what is the end product of our medical education. And that is well recognized. And across the country, as much as efforts are being made to standardize it. The process of selection is really problematic. The entire process of selection is just based on marks and how you actually qualify for marks. At the MBBS level, that may be to some extent acceptable, but at the specialty and the subspecialty level, that is really problematic because the entire focus is on passing these MCQs and qualifying. There is absolutely zero incentive for people with experience and expertise in certain areas or for research or innovative ideas. And so we are actually losing a huge lot of talent who just may not be able to do well or perform on that particular day, while they may actually have the hunger and the passion to actually perform and do that particular job. So that's really a problem. The entire focus is on rote learning rather than on innovation and research. And that is really, really, really a problem in our system. When I talk about disproportionate attention to education in certain areas, when I talk about medical education, I'm talking about strategies to improve healthcare access and equity to all of India. And when you talk about healthcare access and equity to all of India, it does not stop at MBBS, it doesn't stop at doctors. Medical education is a comprehensive involvement of nursing, allied health services, etc., managers, etc., that have to come together to bring about this delivery. And we have actually failed miserably. If you look at our nursing colleagues, we have about 25-30 lakh nurses in India, about 12 lakhs registered with Indian Nursing Council, far short of what we need for this country. 640,000, almost 30 to 40% of them work outside the country. So we need to seriously introspect where have we failed in recognizing and giving value to nursing as a profession. These people are highly valued and skilled people that are grabbed outside, and they thrive and they do extremely well. If you go anywhere in the world, Indian nurses are highly valued. They are not valued in our country, and I think that's something that we should seriously look at why that has happened. When I talk about skewed priorities in medical education, what I'm trying to say is, again, looking at the concept of equity and access to all, what does this country need? And I'm happy that there was a session before this talking on primary health care. The biggest lacunae is not high-end specialty care in India, which in most of the metros is probably as good as anywhere in the world, but it's a huge lacunae in the primary and secondary care delivery. And for that, what we really need is an increased attention to family medicine and general practitioners. We have family medicine as a specialty is only there about 500 seats, There are only about 5,000. There are far more cardiologists and gastroenterologists and neurosurgeons than there are family practitioners. What is required in a country is about 70 per 100,000 to about 140 per 100,000 of family practitioners. What India has is about 0.36, highly undervalued. And these undervaluations are subtle and sometimes pretty obvious, and we take it for granted. For example, the terminology, super specialty. Who does not want to be a super specialist? Everybody wants to be super. In fact, that's a wrong terminology. It's a subspecialty. It's not a super specialty. In fact, the hardest thing to do is general medicine and family medicine. It is the subtle context that we use that actually is ingrained in our system that drives it. Everybody chases money and power. Sitting in this room, I think everybody knows that well. And that's not different for doctors either. So we have to incentivize it, and it is not always monetary. If you have family medicine, it has to be valued at the level, at the primary healthcare, at the secondary hospital healthcare, at the district hospital care. There has to be a mechanism to recognize their management skills. They have to be integral and valued. And I think there's a lot that this country can do to improve access to this. So both in terms of education beyond doctors, there is many aspects. I've taken illustration of nurses. There's the whole branch of allied health services. There's the concept of specialists, and what we really need as a country is different from what we are getting. And finally, there are areas of our medical delivery systems that are really missing in the big picture of healthcare delivery. There's a lot of hype on AI. There's a lot of hype on technology, and rightfully so. I'm sure there is a future for this. But in this whole process, let's not forget the person in the last mile. We are not able to get a 10 rupee hydroxyurea to the last sickle patient in this country. I'm talking about 10 rupees capsule of hydroxyurea every day to a person with sickle cell anemia. We have major logistic and delivery challenges in our healthcare systems and gaps that any successful business will balk at if you look at a healthcare system as a business. It's just not done well. So while we talk about these future things, there are ground realities and vast disparities in people who cannot access the very basic of basics. And I think I'll leave you with that. And I'll say this is a great moment to be. First time I'm addressing an audience like this. I'll leave you with the lines from Ek Pyar Ka Nagma Hai, Do Pal Ki Ye Jeevan Hai, Ek Umr Churani Hai. So let's work together to do that.
Thank you so much, sir. Thank you so much for that fantastic presentation. We are running out of time. We have ran out of time, and we won't have any question and answers. But thanks, Anna, for mentioning that there is a global perspective. There is a lot of resilience and change which needs to happen. Thank you, Vijay Ojha, sir, that a lot of competency-based medical education which brought in, and then a lot of MSMER and PGMER, which is bringing in a regulatory approach to the medical education. Thanks, Dr. Abhijat, sir. You mentioned about the physical, digital, skill-based education system and technology adoption which is happening. Thank you, sir, for very sumptuous and delicious and anarkali presentation. And he is the Mughal-e-Azam, and it was very, very good what you mentioned, Dr. Matthew, that it is the hardest thing to do is a broad specialty work, and it is very important to not miss that important and very essential and critical element like family medicine and GPs which are missing. Thank you so much for being here, and thank you so much for sharing those.
Last but not the least, if I am asked that what is the take-home message from me to the FICCI, then I would say that it requires a very active participation from the FICCI. If you are interested in the industry of medical education, you need good doctors and to run your best hospitals and medical industry. And for making the good doctors, you have to run after us. And you have to see, you have to find out our faults, be active participant in the education process of the country. Thank you.
You will see a lot of people running tomorrow, sir. Thank you so much.
Thank you very much, Dr. Sanjeev Singh, for moderating the session so well, and thank you all the panelists. I know Dr. Achal Gulati sir has given a strike and little hunger has rose in everyone's tummy, but kindly hold on for one more session. The session is on building bridges of trust, strengthening India's healthcare ecosystem.